I was asked here at ASH to give a talk a little bit about the utility and continued utility of cytotoxic induction therapy in acute myeloid leukemia. So we've been using agents like daunorubicin and cytarabine since the early 1970s, but there's all these novel agents that have become available because of genomic work in the last 20 years or so. Agents that are targeted, for example, against the IDH1 or IDH2 mutations, agents that might be able to reduce the FLT3 burden in certain patients with acute leukemia. So I think there's this optimistic question of, are we ready to get rid of cytotoxic therapy in acute leukemia? And my job at this particular session was to really argue that it's too early to throw the baby out with the bathwater here, that cytotoxic therapy does something that all the targeted agents in the world don't do, and that's treat what is common amongst AML rather than what's different amongst AML. And what is common in acute myeloid leukemia is that the stem cell duplicates more quickly. I tell my fellows, for example, that cytotoxic therapy is the original targeted agent. So in somewhat of a review of things, the standard of care for acute leukemia in 2018 remains a backbone of daunorubicin and cytarabine. I think there's little debate now that intensive daunorubicin should be used, or idarubicin, but that 45 milligrams per meter squared shouldn't be used outside of a clinical trial. I think we can safely put aside the question of high-dose cytarabine, again, except in the setting of a clinical trial or perhaps in relapsed refractory disease. And I think we've learned now that certain agents, targeted agents, do best when they're layered on top of cytotoxic therapy. Evidence, for example, of using midostaurin in combination with a backbone of 7+3, or agents like gemtuzumab, the CD33 conjugated antibody, in patients with intermediate risk or favorable risk disease, does show improved survival. So the future doesn't lay in getting rid of what we've already learned works. I think the future lays in understanding how to use novel agents either layered on top of our induction therapy or chronologically during it to really get at that leukemic stem cell and eradicate it.